Give me one. Hello, everyone. Thank you for joining. The title of the article I'm presenting today is Diagnostic Accuracy and Prognostic Implication of Pelvic and Peritoneal Fluid Cytology Specimens in Ovarian Clear Cell Carcinoma. I'm Dr. Seema Khutti, and I am from Northwell, New York. And I practice cytopathology and gynecologic pathology, so this title is definitely of my interest. And this article was recently published in JASC Medical Journal in the month of February. Authors are Dr. Mason Marshall and Dr. Khader, and from UPMC, Pennsylvania. And we are fortunate that both authors are present during our live webinar. And I have no disclosures. This is me. And this is Mason Marshall. He's currently a chief resident, and I think he's going for cytopath fellowship next year at UPMC. And Dr. Khader, who is the senior director of cytopathology, system director, as well as the director for cytopathology fellowship program at UPMC. So the objective of this study were to investigate the diagnostic performance of abdominal pelvic fluid cytology specimens in cases with pure ovarian clear cell carcinoma, and to determine the factors that impact the cytologic detection, and also to reaffirm the importance of accurate cytologic detection and its impact on patient prognosis. Ovarian clear cell carcinoma is a rare subtype of ovarian epithelial carcinoma, and it constitutes about 5 to 10% of all epithelial carcinoma in the United States. It's usually associated with endometriosis in approximately half of the cases, and as well as the Lynch syndrome. Usually it is present in young patients, unilateral, and it is diagnosed at an early stage. When compared to the other subtypes of epithelial carcinoma. Morphologically, it's characterized by clear or cells with clear to eosinophilic cytoplasm in various growth patterns such as papillary, solid, or tubulocystic. The most frequent mutations are ARID1 and PIK3CA, approximately in 50% of the cases. But this tumor, although high grade, they are not sensitive to platinum-based chemotherapy as in serous carcinoma. They are quite resistant to chemotherapy. The neoplastic cells, however, when present in pelvic wash, upstages the patient to at least FIGO 1C3 stage, and it indicates the spread of disease. The upstaging on the grounds of cytology only occurs in approximately 20% of the cases. The pelvic cytology in ovarian clear cell carcinoma confers worse prognosis, and hence the pelvic wash cytology specimens are very essential for accurate staging of the disease and further management. So I do have a quick question for our authors here. I'll direct first question to Mason, who's the first author on this study. So what was the motivation or inspiration to start this project?
I would say it's kind of twofold. The first is that I was fortunate to do gynecologic pathology. Was my first rotation in residency, and I remember just kind of being fascinated with ovarian tumors that we would see at frozen section. Remember seeing a few tumors that were greater than 30, 35 pounds that had to be kind of wheeled in from the ORs on a bucket. And so that really kind of got me interested in ovarian tumors and ovarian neoplasia. And then the second was that I remember just seeing a clear cell for the first time, and I just found them to be a histologically beautiful tumor, and kind of captivated me that way. So I wanted to look into it further.
So just a second consecutive, like, why did you focus only on clear cell carcinoma?
I would say when I dug into the literature, I kind of came across the MSK cohort, which very beautifully demonstrates the poor prognostic impact of positive cytology. But then my question was, well, how do we do on these specimens? And when I searched into the literature, I couldn't find anything. So kind of found a void and wanted to fill it.
Interesting, thank you. So now we'll move forward and to the material and method sections for the study. So the authors, all the cases which were treated for ovarian clear cell carcinoma between the time period was from July 2002 to 2022. They reviewed the medical records. And the inclusion criteria were only the cases with companion pelvic wash or ascitic fluid cytology at the time of initial resection were included in the study. They excluded any clear cell carcinoma if it was part of a mixed tumor or carcinosarcoma, or if it was a recurrent disease. Those cases were excluded. The demographics, the type of specimen, the volume of the fluids, and date and nature of the follow-up were all recorded. And if any IHCs were performed on positive cases, that were also noted. And then after that, cases were sorted by FIGO stage of the corresponding surgical specimen. And then after, a detection rate was determined for each stage. The association between the fluid specimen type as well as the detection rate were tested using the Fisher exit test. I think also the follow-up data was available in 127 cases, and then the authors compared the frequency distribution of survival from death by disease stage as determined by the positive fluid cytology with the Fisher exit test or chi-square test. Also, Kaplan-Meier survival probability curves by 6 months from the fluid cytology evaluation were compared with the log rank test statistic. So I would take a quick pause here and would have one more question for authors here. It looks very comprehensive study. What was the most challenging part of the study for you?
I would say certainly the most challenging and the most labor intensive was probably actually the data collection. We use COPATH in our institution, and often when we search that, we use a natural language search, for which the phrase clear cell carcinoma was the highest yield for me. But that of course pulls in endometrial clear cell carcinomas, clear cell renal cell carcinomas get pulled into that, squamous cell carcinomas with clear cell features. So I think if memory serves, I ended up with like close to a 2,000 page PDF that I kind of went through individual cases and then to see if they had a companion cytology specimen, which of course you can see was fairly fruitful, yielding a cohort of 143 patients, which is the largest in the literature. But then I also had 143 patients to kind of dig into the charts. Thankfully, our oncologists in system write very good detailed notes, so the clinical pathologic characteristics weren't as painful to collect as maybe they could have been otherwise.
Thank you. It was impressive that you had all the most clinical data, with cytology studies are very hard otherwise. So moving on to the results. So in total, they had 143 cases of pure ovarian clear cell carcinoma with companion fluid cytology specimens. The age range was very wider, from 30 years to 88 years, the median being 57 years. If we compare the stage-wise distribution, the most common subgroup was stage 1 cases, and which comprised of 59% of the entire cohort, followed by stage 3, which was 26.6%, followed by stage 2, there were 14 cases, which was around 9.7%, and stage 4, only 2 cases were there. Within stage 1, the most common, as expected, was stage 1C with 39 cases out of total 84 cases, and then was 1A with 43 and 1B with only 2 cases. Within stage 3, the most common subgroup again was 3C with 20 cases, followed by 3A with 14 cases and 4 cases in 3B subgroup. So within the entire cohort, the positive cytology was noted in 38% of the cases, which were 54 cases, and they were negative in 58.7%, which was around 84 cases, and only 5 cases were in intermediate findings, which were either atypical or suspicious, which was quite impressive, I would say. Within the stage 1C cohort, which were 39 cases, 16 of those cases had malignant cytology. And of those 16 cases, 8 cases, which is 50% of the stage 1C cases, were upstage based on cytology alone without any capsular or surface involvement. The detection rates, if they were older cases of FIGO 2A and 2B, they were reclassified and it reached up to 50% and 40% respectively. And there were 2 cases with stage 1A and 1 case with stage 1C, which was diagnosed as a suspicious. Within FIGO stage 3, the detection rate, of course, as expected, was very high, which is 79%, and the distribution was 9 out of 3A cases were positive, and all 3B were positive, and 17 out of 23C cases was positive cytology. And stage 4, of course, had both cases with positive cytology. So this is just a diagrammatic representation of cytologic detection rate by FIGO substage. And as we can see, as the stage advanced, the detection rate also increased. And within that substage, we can see 3B has the highest, equivalent almost to 4, followed by 3C, and then followed by 3A. Type of specimens, so out of 143 cases, majority were pelvic wash, around 98 cases, and there were 45 ascitic fluid specimens. And the overall detection rate was fluid was, of course, higher, which is 63% compared to pelvic wash, which was 27.5%. Both specimen types had around approximately 3% of intermediate cases with atypical or suspicious finding. Within stage 1C, ascitic fluid has a higher detection rate of approximately 76.9%, whereas only 23% of pelvic wash were positive in that subgroup. So this is again a diagrammatic representation. This chart here nicely demonstrates that it was throughout the type of specimen, which was either ascitic fluid or pelvic wash, relatively similar on 3C and 3B. However, in 1C group, ascitic fluid performed very well compared to pelvic wash. And here, this was a impact of the positive slide on a 5-year survival among the stage 1A disease. So they compared the survival probability among those classified as either stage 1A, 1B, or 1C with negative cytology, which was around 0.89, to the survival probability of those cases with stage 1C and positive cytology, which was 0.69. And they found this difference to approach a very near the statistical significance by log rank test value of 0.06. This is the next figure here. It demonstrates an increasingly poor prognosis as the disease stage increases. In stage 1, there were 75 cases. The probability of survival was 0.86, while stage 2 and stage 3 had probability overall survival values of 0.54 and 0.19 respectively. And again, this was statistically significant. If there were immunos performed on positive cases, the data was recorded, and as there were only 11 cases out of all those positive cases where IHC was performed, and the most commonly used markers were BORI-P4 and MOG31, or both in 7.7% of the cases. So that's all about this results within this study done. And I do have a quick question again for authors here, that it was very impressive for me, being cytopathologist as well as gynecologic pathologist, that only if you have a handful of cases with intermediate findings which are atypical and suspicious. And in daily practice, those are the cases which we really need input from both ends, cyto as well as search path. So Dr. Khader, how do you approach these cases in your daily practice?
That's an excellent question. Definitely, I mean, fluid cytopathology can be challenging, and I think cytopathologists and pathology in general can utilize fluid cytopathology to obtain a lot of information. That's one example that is very important, how it can upstage the patient. The reason why, in my opinion, the number was low in cases like this, that because we try every effort to handle indeterminate cases that is suspicious or atypical, and try to classify them, especially in cases that are important because it's going to come up in a different reports, right? With every pelvic wash or ascitic fluid, we have a cell block. And oftentimes, if we feel the cell block is inadequate, we could also go and obtain more material from if we have the volume that's enough, like if we have, let's say, more than 75 ml. And additionally, we routinely do immunohistochemical stains. Some of them are indicated here in this slide. Perab Mark 31. In addition to that, we use Claudin 4. Sometimes also we use mucicarmin as a special stain to try to determine if there is real involvement, or to determine what type of tumor is actually involving the fluid specimens in general. So that's why, I mean, the majority of these cases are resolved. We are lucky enough actually that to have very good cell blocks here at UPMC, and most of the time we're able to resolve the case. Now, in the small number of atypical or suspicious, how are we going to deal with that in the synoptic report? And that's, I think, it's another kind of tricky questions for like a gynecologist, pathologist, because I mean, would you consider like an atypical diagnosis as negative or positive here? Because you have to either report it or not report it. So in my opinion, if you tried and you failed in making that diagnosis, you should write a note indicating that the results is suspicious. However, it's a high likability that is going to be involvement versus atypical that should be probably interpreted as negative. So a note should be appropriate here, and classifying men into two tiers, like suspicious and positive, one category, and then negative and atypical into that category. And I think whoever is looking at these samples, if they're not the same person, should understand that differentiating.
Thank you so much for the detailed answer. Now we will move on to the next part, the discussion. Sorry. Okay. So, as mentioned, this was the largest cohort of pure ovarian clear cell carcinoma in literature. It contained more higher stage cases than prior reports. And the median age in their cohort was 57 years, which is similar to the prior studies. And majority of the cases in this study were stage 1A disease, which was also similar to what has been reported in literature prior. And the overall cytologic detection rate was around 38%, which is more accurate regarding ovarian clear cell carcinoma. And the detection rate increased as expected when the substage classifications were removed. The factor impacting detection rate, whether it's type of fluid, pelvic wash versus ascitic fluid, was not statistically significant. And as the stages increase, the cytology findings did not impact when the macroscopic extrapelvic disease is present. And if the cases with equivocal findings, additional slides and cell block could be prepared to try to reach to definitive, which is negative or positive diagnosis, which will be very helpful in practice and management of patients. Atypical or suspicious for malignancy diagnosis was rendered in 2.1 and 1.4% cases respectively in this series, and the two cases were suspicious. Overall, the author's overall survival data confirms that poor prognosis of ovarian clear cell carcinoma in patients with high stage disease. there was one limitation of the study, that the study had small number of patients among certain FIGO stage subgroup, like such as, but that is a real life scenario as well, that these lower stage, either if it is 1B or 2A or 2B, we rarely get those cases confined to just one side of ovary, and they had less than 4 cases in each subgroup, and sorry, less than 7 in patients in each subgroup in this series. In coming on to the conclusion, the positive cytology in low-stage cases of ovarian clear cell carcinoma has significant prognostic as well as therapeutic implications. All efforts should be made in cases with equivocal findings on fluid specimen, including preparing additional slides, cell blocks for definitive determination of either positive or negative results. Stage 1A patients with positive cytology had worse overall survival compared to those with 1A or 1B disease. And the ascitic fluid specimen performed better in this series at a critical 1C junction when compared to the pelvic wash specimens. And thank you all for your kind attention, and we are happy to take any questions if you have.
Yeah, I have a question. Very nice presentation.
Thank you.
Can you hear me? Yes. Okay. So yeah, very interesting. Very I'll say very large study collection, and Dr. Marshall did tremendous work. Now it's very difficult to check medical, to find out interesting cases. For here, same thing, when you use the common word, you pull up like 1,000 of cases. So really, which cases is you were really interested? So that's really a tremendous effort. So also, a good question for us. We have a pathology separated system. So we can enter the keyword, pull out interesting cases. But now, all those old system retired. So we have this updated system, and very difficult to find the cases. Maybe down the road, some pathology, can develop a more advanced system, AI assistant to help us more quickly find, targeted interesting cases. So that's one point. The other point also very interesting. So we know, ascites and pelvic washing. Pelvic washing is part of staging protocol, so they routinely do that. And you compare ascites with surgical washing, you found ascites also had very high yield. And I just wondering for this, our 147 cases, only 11 cases has immuno study. So when you evaluate morphology, those like FIGO grade 1 and FIGO grade 3, what kind of some kind of hint or feature can lead us to thinking about clear cell, carcinoma. Sometimes, morphologic, like you said, overlapping with, several different type of tumors. However, here the very few cases you guys did found those cases at immuno. So any clue, we can, further look at it?
I would agree in that morphology is definitely still the gold standard for OCC. But there's often the background for malignant cases is often kind of dirty or kind of tigroid described in the literature. And then if you see the characteristic raspberry body, that's usually highly not suggestive of ovarian clear cell carcinoma, kind of a central fibrobascular core with malignant cells kind of clinging off that. So those are kind of the two main features that were really helpful for us.
Thank you.
I could add to that that I would recommend actually, that's a very good question. but I would recommend a kind of a liberal approach for doing immunohistochemical stains, because as Mason mentioned, like, you know, they have classic findings, but like at the same time also when you differentiate like reactive mesothelial cells from macrophages from, you know, degenerated tumor cells, that can be a difficult task. And I've honestly seen cases that I did not expect that I'm gonna find tumors, but because I did immunohistochemical stains, because it was degenerated or it was like, you know, a little hyperchromatic, sometimes you see like a prominence of the nucleolus. And I remember over that period of time that I've been attending, like 15 years now, I'm seeing a good number actually of cases that I was surprised that I was more like thinking as the old atypical favor reactive mesothelial cells or favor macrophages, histiocytic proliferation, something like that. But like there are definitely overlapping features. But my recommendation is like, if you think that there is a possibility that these cells are not macrophages or mesothelial cells, just do like, you know, your panel, and your panel can be like as little as, you know, carotene per ep or whatever works for you. Like I oftentimes do like Mach 31, Claudin 4, and carotene as like I think it's stakes are too high for missing case of involvement, especially in cases like clear cell carcinoma.
Thank you.
You know, if we don't have anything in the chat, I'd like to first reiterate what Dr. Lee said. I mean, this was an outstanding presentation, Dr. Khutti, and
Thank you.
of an outstanding project. I'm almost tempted to disagree with the what you listed as the limitations. The numbers were really, I was really impressed with the numbers that you were able to get, and your ability to compile the clinical data. I mean, it's just a really remarkable study. The question I had is, I noticed that for each of your specimens, you made a diff-quick stained cytospin, a PAP stained thin prep, and then an H&E stained FFPE cell block. I'm just curious, which one of those did you tend to find the most helpful, the most diagnostic? You know, for us moving forward in our own labs, what protocol would you recommend for pelvic washings associated with gynecologic malignancies?
Can you take that, Mason?
Sure. I would say I would recommend a combination of at least one thin prep of cytospin plus a cell block. At least one kind of a cytology specimen with a cell block is ideal, like Dr. Khader mentioned, because abdominal kind of fluid cytology can be wrought with challenges. Having a cell block for backup for challenging cases is ideal. If you know you have a obscuring background inflammation, a lot of revved up reactive mesothelial cells, and then of course, like Dr. Khader mentioned as well, the ability to perform IHC can be really invaluable for challenging cases. We didn't have a great number of cases staining for a Pax8 or HNF1 beta, but at least on the surgical side of things, those IHC markers perform very well and can help you in challenging cases. So I think a combination of a cytology specimen with cell block would be ideal.
Yeah, I agree. I mean, liquid-based preparation can be helpful. I think having more than one specimen also kind of limit the artifacts that you can get, like any suboptimal staining. Sometimes the degeneration of cells can affect, like, can be more prominent actually in some type of preparation versus other. I mean, if the resources are available, we do like cell block in every case, and I think that's recommended. I know that the international system like kind of recommend like doing cell block if you need it. That's also like appropriate, especially if you have like limited resources. The reason why we do diff quick is that we like diff quick in general at UPMC, and also that's one thing. It exaggerates the difference between the cells. It shows pleomorphism well. But the major reason is that we have a lot of samples that include hematolymphoid malignancies. So we find that to be very, very helpful. And then we try, as I mentioned, to always have like a good cell block. And we're lucky actually that we have excellent supervisors here that they always keep the cell block quality very high. And we routinely do like molecular testing on cell block material, and also additional immunohistochemical stains for prognostication as well as therapy. Also, with fluid specimens, oftentimes whenever the cytologist is seeing like a specimen that could have like a lot of lymphoid cells, easier on DEFQuick, or like plasmacytoid cells, they ask us if we would like to send for flow. So oftentimes they can like do telecytology with you from the lab, or just bring you a case, and we would do send for flow cytometry. And additionally, sometimes also if they feel that there is a lot of tumor, they would like to order stains. Like they also ask if we can do blanks just to speed up the process. Like I'm sure like a lot of places they have like shortages in terms of staffing for the histology lab, and cases are taking a while. So that's a lot of help, and I think that's how the future should bring like more help from cytologists, as we're going to get hopefully more help from digital pathology as well.
I guess piggybacking off that answer too, what's nice about often these specimens is that you're not typically limited by volumes, more so with the acidic fluids. If memory serves, I think the mean volume for those was over like half a liter. So definitely specimen to go around to make multiple types of preparations in the cell block, which is nice.
That's great. Thank you very much.
I just want to thank AEC committee for this opportunity to present, and thank you all, both the authors, for participating in live webinar. Thank you.
Thank you very much. We thank our mother organization, AEC, and all of you and especially Dr. Khutti. Always great to catch up with you.
Yes.
Thank you everyone for your attention and for the opportunity to share our work.
Thank you.
Thanks so much,
Have a nice
everyone.
day, everyone.
Thank you.
Bye.
Bye.